Hello, everyone. I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about disorders of the thyroid gland. So what's important to know when it comes to thyroid pathology is just how widely they can present. It's one of those things that you'd always keep in the back of your mind when you have vague presentations or you can't really come to a differential. Always consider, could this be a thyroid issue? So there are a few things that you should know when it comes to thyroid stuff. Firstly, you have someone with overt symptoms of either hypo or hyperthyroidism, how to treat them. Secondly, you have a patient presenting with a neck lump. You should know the types of thyroid masses, cancers, how we distinguish and how we treat them. And lastly, you should know about complications of thyroid surgery. So, and going back to some anatomical knowledge, again, not super high yield, but good to know. It's located anterior to the larynx and the trachea between C5 and T1. It produces a few hormones, T3, T4, which are the main ones you know, and calcitonin that has a role in calcium regulation. In terms of its arterial supply, you have two arteries and three veins. You have the superior and inferior thyroid artery, and then the superior, middle, and inferior veins. A few surgical complications when it comes to anatomy that you should know of is firstly damage to the recurrent laryngeal nerve that runs very closely to the thyroid and can cause hoarseness of voice. You can also damage the phrenic nerve that can be associated with hemiparalysis of the diaphragm. And lastly, because the thyroid is obviously a gland, it requires a lot of blood supply. And because of its high vascularity, it is very prone to bleeding. And therefore, when you stitch up the thyroid and close the wound, because it's such a tight space as well, because of the different fascia, any bleeding can cause compressive symptoms very easily. And it's one of the big complications we worry about because it can compress on the trachea and cause suffocation. So going back to a bit about the physiology when it comes to the thyroid, I'm covering a few important bits, but it's not going to be very extensive. The hypothalamus releases thyroid releasing hormone, TRH, that acts on the anterior pituitary. The anterior pituitary produces TSH, or thyroid stimulating hormone. This acts on the thyroid gland, and the thyroid gland releases T3 and T4. T3 is more active, while there is more of T4, and both of these hormones feed back to the pituitary and closely interact with TSH. A large proportion is converted from T3 to T4, from T4 to T3, both in the thyroid and peripheral tissue. And this is relevant because one of the anti-thyroid medications we use, PPE or propylthyrouracil, prevents this peripheral conversion. So how is this produced? So you have the regulation of thyroid production being done by the TSH hormone. Increased levels of TSH cause increase in T3 and T4 production and vice versa. The production happens in the follicular cells. You have a basolateral membrane containing sodium iodine transporters, and obviously iodine is a very important mineral when it comes to thyroid function, and iodine deficiency can cause a goiter. That's something you need to know. Basically, what happens is you have the production or trapping of the ion molecules that together which together are packaged within the rough endoplasmic reticulum, or the RER, to secrete thyroglobulins. And these thyroglobulin molecules are then secreted into the colloids through exocytosis. And here's a graphical representation of that. Now, what you need to know is that most of the hormone actually in the blood is not free hormone. It's actually bound to transport proteins. The three relevant ones are TBG, or thyroxine binding globulin, thyrotin, and albumin. And here are the three with the relative concentrations and affinities. So as you can see, you have 2,000 times as much albumin as you do TBG, but the affinity or the tendency of T3 and T4 to bind to TBG is very, very significantly greater than that of albumin. You have about 75% of T4 and T3 bound to TBG, although albumin's concentration in the blood is 2,000 times that. Only 0.4% of T3 and 0.04% of T4 is unbound. Now, you need to know that up to 1/3 of T4 is deionized peripherally. So T4, we take away an iodine to form T3. And this is because T3 has a greater potency and acts more on peripheral tissue. It's about 4 times that of T4. Now, even though T3 and T4 are lipophilic, and when we talk about hormones, we can either group them into being lipophilic or lipophobic, depending on how easily they can cross through a membrane. But although they are lipophilic, they are often dependent on ATP carrier mechanisms to pass the cell membrane. And this is weird because it's not typical of lipophilic hormones. Now, thyroid receptors are located everywhere, and they're bound to DNA, which is why these hormones have to enter the cell to act. Upon binding, you have a whole range of functions, and here are the main ones that are relevant. You can just read over them. Some important ones are the basal metabolic rate, which would be increased with hyperthyroidism, protein catabolism or breakdown, gut motility, and gluconeogenesis and glycogenolysis. So this just means producing more glucose and breaking down glycogen to likewise produce glucose. Now, talking about feedback loops, now T3 and T4 are involved in feedback loops with both the anti-pituitary and the hypothalamus. So at the level of the anti-pituitary, this is to do with TSH, while it's to do with TRH at the level of the hypothalamus. Funnily enough, exposure to cold environments actually increases TSH secretion. And this kind of makes sense because by increasing TSH secretion, you can increase T3 and T4 levels, which up your basal metabolic rate, up your body's exogenic capacity. And the maximum secretion of TSH is between midnight and 4 a.m. Factors that stimulate TSH include TRH, low levels of circulating hormones, as well as estrogen, and inhibitors include things like somatostatin, growth hormone, cortisol, and so on. So now let's interpret some TFTs. Now, so this is, again, some clinically relevant stuff. The first thing you need to know is that whenever you look at TFTs, and whenever you order TFTs, you very rarely order everything at once. So the relevant ones are TSH, T3, and T4. We almost always start with the TSH first. Now, why do we just do the TSH? Why don't we just do T3 and T4 as well? Now, here's a summary of everything and how every thyroid kind of pathology presents. Just have a look at TSH. As you can see, if you have an issue with the thyroid that is significant, you are almost always going to have changes to TSH, and you cannot have changes to T3, T4 with the typical TSH, with the normal TSH. That's very abnormal. It does not happen. So let's talk about a few of these and how they come up in exams and on the wards in hospital. You need to know the difference between primary and secondary hyper versus hypothyroidism. Whenever I say primary, it means that the issue is at the level of the thyroid gland. Secondary means it's at the level of the pituitary. Tertiary would be at the level of the hypothalamus. But we often group secondary and tertiary into central because they both present similarly on TFTs. So let's go through each one of these cases. Primary hypothyroidism. So primary meaning it's at the level of the thyroid, hypo meaning low, thyroid meaning production of thyroid hormones. You have low levels of thyroid hormones because of an issue at the thyroid. This can be due to things like Hashimoto's thyroiditis, goiters and masses. But all this means is that you will have low levels of circulating thyroid hormone and high levels of TSH, right? Because your pituitary would be trying to increase the secretion of T3 and T4. Now we have this unique thing called subclinical hypothyroidism. So what does this mean? So with subclinical hypothyroidism, the way I like to think about this and visualize what's going on, I think to myself, well, we had an issue with the thyroid. Let's say it's working at a reduced capacity to begin with. So it started off producing lesser amounts of T3 and T4. Over time, your TSH, your pituitary picked up on that change and brought up the levels of TSH. And by secreting more TSH, you've kind of pushed your thyroid into overdrive and normalized the levels of T3 and T4. Now, this is still relevant because your thyroid is not working at its maximum efficiency. However, from a clinical perspective, you will not see any signs because the hormones that act on tissue and cause all your signs and symptoms of hyper or hypothyroidism have to do with levels of T3 and T4. And as I just said, with subclinical hypothyroidism, you have normal levels of T3, T4, although your TSH may be abnormal. Hopefully that makes sense. With central hypothyroidism, you have a failure either at the level of the hypothalamus or the pituitary, and this would lead to low levels of TSH, causing low levels of thyroid hormone. And the rest is just the complete opposite of that. Now, what are the signs and symptoms or findings of each one? So hypothyroidism, also called thyrotoxicosis, sweating, which is a good way to remember it because the S for sweating, weight loss, emotional ability, increased in appetite, despite weight loss, that's very important, having a tremor as well as a tachycardia, intolerance to heat or feeling hot, nervousness, and a goiter or GI problems, mostly diarrhea. And then hypothyroidism, which isn't as neat as sweating, but wish, firm, cap. So again, the complete opposite to all of these. So if you just remember hyper, you can very easily put together hypo. So hypothyroidism is also called thyrotoxicosis. So here are the causes of hypothyroidism in order of prevalence. So Graves' disease is most common. Then you have multinodular goiters, adenomas that can be active, and thyroiditis or inflammation of the thyroid. And then you have medications. Lastly, you have TSH-mediated causes like pituitary tumors. So if you have a pituitary tumor that's secreting TSH, that would cause secondary or central hyperthyroidism, but that is extremely rare. Now, Graves' disease mostly presents in women because it's autoimmune and is the most common cause of hyperthyroidism, as I mentioned. Now, it's autoimmune, but it's a bit weird because when we talk about autoimmune, we usually talk about things or antibodies attacking and breaking down and basically limiting the role of certain tissue. But with Graves' disease, you have antibodies. However, instead of being deactivating antibodies, these are activating antibodies. So they're called TSH autoantibodies, and they act on the TSH receptors. So they're not TSH, but they act on the receptors and basically mimic the role of TSH. How can we pick this up? So we'll be having all the general signs and symptoms of hyperthyroidism, which are listed here. But additionally, you have a few extra features that might make you think, well, this might be Graves. Now, what are they? Here is Graves. I'm sure you've seen issues with the eyes. So things are specific to Graves, thyroid, ophthalmopathy. That was a struggle. So this is really important to understand. So you have your thyroid TSH receptor antibodies, okay? In addition to acting at the TSH receptors, they also react with the fat cells around and behind the eye. They cause the infiltration of B and T cells, causing fibroblast proliferation. All this means is you're going to have a whole bunch more of fat cells behind and around the eye in the form of fatty fibrosis, which would push the eye out, causing exophthalmostosis and lid retraction, resistance to ocular muscles, which is why you have ophthalmoplegias and diplopia. The reason I care about this and stress this is because this is not an issue with thyroid levels. When we talk about managing Graves' disease, I'll talk about how we can either cut out a part of the thyroid, give them anti-thyroid medications, control their symptoms, but this has nothing to do with that. This is TSH receptor antibodies acting at fat cells. It's completely immune, unrelated to thyroid issues. So unless we can somehow suppress the autoimmune process going on, you cannot reverse or fix this eye issue, which is why it's relevant. So patients may ask, so doc, you put me on this new medication and my symptoms have improved, but my eyes are still wonky. And that is why it happens. And next we have this thing called pretibial mixed edema, which refers to an inflammatory process very similar to what's going on in the fat cell behind the eye, happening now in the pretibial subcutaneous tissue. And I think I have a picture of both of them. So here's your ptosis with lid retraction. Typically, the lid should extend until you should cover the iris. You should not see the white part of the eye superiorly. And then with the pretibial mixed edema, this is a non-pitting edema, which is different to the edema you see with chronic kidney disease, liver failure, and heart failure, which is pitting edema. Now, multinodular goiter, as name suggests, you have an issue with many, so you have multiple nodes, and this can increase the size of the thyroid gland and can also be, and can also lead to hyperthyroidism. However, you very rarely see hyperplastic or dysplastic changes, so it's a relatively benign condition. You still need to consider some other causes for a goiter when you see something like this. So things like iodine deficiency, Graves' disease, thyroiditis, Hashimoto's, all are relevant things to consider. Complications of a goiter, obviously, firstly, just the thyroid hormonal issues, but then we also have to worry about compressive stuff. So tracheal compression, nerve compression, and then you can also have lymph node enlargement if you have a malignancy, but that's going to be rare with a goiter because most malignant thyroid pathologies don't present with a goiter. So how do we treat hypothyroidism? First step is anti-thyroid drug therapy, and we have two different medications. We have carbimazole. So carbimazole prevents ionization at the level of the thyroid. So don't give this to pregnant women because you need iodine and iodization in pregnant women, so it's contraindicated. But then the other complication that is very, very important to know is this thing called agranulocytosis, where you basically stop making granulated cells, particularly neutrophils. And because you have basically agranulocytosis with a zilch neutrophil count, you are at a very high risk of infections. And if you get infections, you can't fight the infections. So a fever in any patient on carbimazole is a big worry. And there's a specific algorithm for managing fevers and agranulocytosis. And obviously, this is a very rare complication. Next, we have PPU, or propyl thiouracil. Instead of acting at the level of the thyroid, it prevents peripheral conversion of T4 to T3 and the safety use in pregnancy. Additionally, we can manage their symptoms by stuff like beta blockades and manage their GI symptoms as well. For Graves' ophthalmoplegia, you would refer them on to a surgeon. Next, we have hypothyroid. So we already know the signs and symptoms we'll expect. The important causes are Hashimoto's, postpartum thyroiditis, subacute granulomatous thyroiditis or de Quervain's thyroiditis, and congenital hypothyroidism. Now, the ones that you should know well, I'd say Hashimoto's, definitely know it really well. The rest, if you don't know it, I don't think it'll be the end of the world. With Hashimoto's, you again have an autoimmune process, but now instead of being an activating process, it's a destructive process. So the way it works is you can often have a transient hypothyroidism before going into hypo. Now, how does this make sense? Well, as we said, we have our thyroglobulin and our T3, T4, which is packaged in nice follicles in the thyroid. When we start destructing the thyroid, we have often a transient leakage of this hormone that we already have packaged and ready to go into the bloodstream. And therefore, we can have signs and symptoms of hyperthyroidism for a short period of time before everything crashes and your thyroid can no longer produce hormones, and that would lead to hypothyroidism. Next, we have postpartum thyroiditis. That is often, again, a complication of complicated pregnancies. And then we have a few more that I've briefly talked about here, whether they are painful, painless, what the antibodies specifically are, but I don't think this is very high yield. You should know, though, that Hashimoto is associated with anti-TPO and thyroglobulin antibody. In terms of treating hypothyroid, the drug of choice is going to be levothyroxine, and they're going to be on lifelong therapy in most cases. A few other important points to consider is that you should increase the level of this of your replacement if they're pregnant, because you have increased needs, but then also in periods of increased stress, it's relevant to know. And when you have newborns with congenital issues, you need to know that the thyroid levels should be fixed very, very soon, because thyroid has a very important role in neurodevelopment. And we worry obviously about mixed edema coma. So when it comes to thyroid nodules, you now have a patient with a lump in their neck, and this is obviously worrisome. So a few questions we have to ask ourselves. Firstly, is this from the thyroid? Is this a lymph node mass? Is it muscular or fibrous? And how do we go about differentiating that? So firstly, see if you can palpate it with the rest of the thyroid. Is it consistent with the borders themselves? Next, get them to swallow water. Does it move up? And usually the thyroid should. Or is it a fixed mass or fixed to the skin, which might indicate a subcutaneous lesion? You ask them to stick their tongue out. Does it rise? If it does, it's a thyroglossal cyst, which is often a remnant of thyroglossal development, which arises from the back of the tongue as the thyroid migrates downwards. If that's left, it can cause a thyroglossal cyst present in the thyroglossal duct. And is it mobile or is it fixed to the skin? Lastly, you can also percuss and see if there is any retrosternal extension of the thyroid, but this is more so to be seen in massive goiters. Second, is it a lymph node? So palpate the rest of the head and neck, assess lymph node status. Is it painful? Is it painless? And obviously, if they have things like weight loss or symptoms of a particular system malignancy, obviously look out for that. And is it muscular or fibrous? Get them to turn their head and palpate the sternocleidomastoid and see if it is attached to the underlying muscle. So what can a thyroid nodule be? So most thyroid nodules are non-neoplastic, which is reassuring. It could just be a simple colloid nodule, a hypoplastic nodule, a cyst, but then some neoplastic things that we worry about. It could be a benign adenoma, which is still a growth. It can be a carcinoma that is malignant. And the types of carcinomas that you, in my opinion, should know, you have papillary, follicular, medullary, and anaplastic. And we talk about each one of them in a bit. So when it comes to assessing thyroid masses, firstly, you want to do a TSH. And what we think or we look for is a low TSH, which is reassuring because this would probably mean that this nodule is an active nodule, right? The thing we're worried about whenever you see a thyroid nodule is this cancer? And you need to know that most cancers are non-secretory, which would have a low, a normal or a high TSH even. So a low TSH usually means a solitary adenoma. We don't really worry about it as much. Versus if you have a normal TSH, then you think, well, could this be a cancer? And based on the features of the thyroid and the lymph nodes, you might also do an FNA. Depending on how suspicious it is, we have different recommendations for FNAs and what size should the nodule be to actually intervene. And here is the summary table that I really like of the different types of cancers. Some important points I would make. In terms of, firstly, prognosis, great prognosis with papillary, good prognosis with follicular, okayish with medullary, and very poor with anaplastic. The way I like to think about this is the more common, the better the prognosis, which obviously differs to renal cancers, which are the complete opposite. Local growth, anaplastic cancers, because have a very poor prognosis, grow locally quite extensively and can metastasize, can undergo metastasis really early on through both blood and lymph. Other things are that papillary cancers typically spread through lymph nodes, while follicular cancers often spread through the blood. The way I remember this is follicular cancers arise in the follicles. Follicles are the places that produce the hormone, and therefore that part will be very well vascularized, and therefore hematological spread more common. Some important things from a pathology perspective. So you have Simone bodies with papillary cancers and orphan Annie eyes, or often any-eyed nuclear grooves. Lastly, with medullary cancers, so medullary cells or C cells produce calcitonin, and calcitonin obviously has a role in calcium metabolism. So you can actually use calcitonin as a marker for monitoring medullary cancer prognosis. So surgeries, you can do a few things. Oops, I realized I messed up the transitions on that. So you can either take out the entire thyroid gland, called a total thyroidectomy. You can take out most of it, but leave a bit behind, called a subtotal. Take out half, or just take out a lobe. Some reasons you might do that include, obviously, if you have a cancer, you might want to resect it, but then benign conditions as well, like Graves and multinodular goiters. Pre-op considerations include ensuring euthyroid status. So we always want to ensure that if they're hyper, we want to get them down. If they're hypo, we want to supplement them with levothyroxine, and giving them calcium and vitamin D supplementation because of that role with the parathyroid gland. And as we know, the parathyroid gland can often be damaged in thyroid surgery. Some other important considerations to know and complications to know include palsies, hematomas, damage to the parathyroid, and a thyroid storm, typical of inflammatory change. And that is all we had for disorders of the thyroid gland. Thank you all for coming. As always, any questions, shoot me a message, and please look after yourself and please look after your loved ones.